First of all, I would like to thank the Sri Lanka Association of Urological Surgeons for the invitation. It's a great privilege and honor to be here. Interventional radiology, supportive adjunct to urological practice. Interventional radiology has been constantly developing in terms of the techniques, materials, methods, interacting with all areas of medicine. Advances in imaging techniques, especially in the last 2 decades, have led to a paradigm shift in the field of urological interventions. During my presentation, I would like to cover the obstructive uropathy, macroscopic hematuria, focal therapy in small renal mass, biopsy and drainages. The advantages of such interventional procedures include a lower risk of complications, can be performed under local anesthesia and sedation, minimizing the risk of adverse post-anesthesia events in comparison with general anesthesia, and there will be short hospital stay and obviously minimally invasive. Obstructive uropathy. The drainage of the urinary tract can be accomplished by several techniques and devices, including antegrade percutaneous insertion of the double J stents and percutaneous nephrostomies. Percutaneous double J stent restores the physiological urinary drainage without need for an external catheter. This is one such example of a moderate to gross hydronephrosis and proximal hydroureter. After getting the access via percutaneous puncture under ultrasound guidance, the nephrostogram revealed obstruction and the blockade of the existing DJ stent. And following insertion of the nephrostomy tube, there was thick pus. This is another example of bilateral moderate hydronephrosis due to bladder infiltration. Again, we use both ultrasound and fluoroscopy guidance. This is the needle and getting into the PC system, this time in the right side, and negotiating the wire through the ureter lower down. The obstruction is manipulated and traversed and getting into the bladder. Finally, we will push the double J stent. Macroscopic hematuria. Embolization is a minimally invasive procedure in which the lumen of a vessel is occluded by embolization material with reported success rates of up to 90%. Indications include persistent hematuria resulting from a pseudoaneurysm, post-biopsy arteriovenous fistulas, renal tumors and recurrence of prostate cancer, vascular malformations, surgical or accidental trauma. The material we use are usually glue and vascular coils. This is an example of pseudoaneurysm associated with the AV fistula. The reconstructed CT images clearly shows a feeding vessel into a pseudoaneurysm, and the selective renal angiogram demonstrates high flow fistula associated with this aneurysm. Subsequently, it was embolized using microcoils, pushable coils, and the final spot image shows the coils in relation to the kidney, and the fistula was cured on table. Another example with a large pseudoaneurysm arising from one of the branches of the right renal artery. The reconstructed MRI clearly shows a feeding vessel leading into this aneurysm. Selective renal angiogram demonstrates the pseudoaneurysm, and it was treated with pushable coils again. These are some framing coils. Then it was filled with small coils. And the final renal angiogram demonstrates the exclusion of the pseudoaneurysm with preservation of the surrounding normal parenchyma. Similarly, in certain instances, we can embolize angiolipomas as well, especially when the patient is presented with hematoma. So in this patient, there's a large mass in relation to the left kidney, and this was the selective renal angiogram demonstrating abnormal blood vessels in relation to the upper pole. So this was subsequently embolized. Prostate artery embolization. In selected patients, we do embolization of prostate arteries. Meticulous care is needed in order to avoid the adjacent structures such as the penile artery, the vesical branches and rectal branches. So this is a reconstructed image showing the prostate artery. This is the grossly enlarged prostate, and these are selective angiograms demonstrating the prostate artery. We need to cannulate both sides in order to get the maximum benefit. So this is a selective catheterization of the right prostate artery before embolization. Fistulogram and fistuloplasty in compromised patient with renal failure. This is one example of a radiocephalic AVF with a just anastomotic tight stricture. So this was treated with balloon angioplasty. As you can see, the final fistulogram demonstrates the restoration of the lumen in the stenotic segment. Another example of a brachiocephalic AVF with another tight stricture in the arm as well as in the just anastomotic venous component. Again, this was treated with venoplasty, with balloon-assisted venoplasty. Another example of a central venous occlusion. This time it was the left brachiocephalic vein. As you can see in the first image, there's a tight stricture with refilling of the retrograde filling of the internal jugular vein and arteries, and this was treated with negotiation of a wire through the tight stricture here and subsequent balloon dilatation. The final central venogram shows the normal flow across the left brachiocephalic vein. Focal therapy in small renal masses. Small renal masses, we consider them less than 4 centimeters, account for half of the diagnosed renal masses. And size at diagnosis is getting smaller and more localized. The principle of treatment is renal preserving without compromising the oncologic outcome. The targeted area is T1A renal cell carcinomas, like I mentioned. The rate of complications are very low. The procedure is minimally invasive and may be performed under sedation and as a daycare patient. So, percutaneous ablation may lead to 100% ablation in tumors smaller than 3 centimeters and up to 90% with the sizes between 3 and 5 centimeters. The technique was first published in 1998. There are different modalities: radiofrequency ablations, microwave ablation, and cryoablation. So first two are available in Sri Lanka. The cryoablation is we are not using at the moment in Sri Lanka. Pre-treatment imaging is very important to assess the feasibility of the procedure, the site of access, number and the pathway of the probes, the risk of adjacent organ injury. This is very important to reduce the complications of ablation, and the necessity of ancillary procedures. So indications, the presence of comorbidities that would increase the risk of surgical interventions such as COPD and heart failure, single functioning kidneys, impaired renal function, and presence of more than one small renal tumors. Contraindications, uncorrectable coagulopathy and extensive spinal deformities that we cannot access the percutaneous route. So those things will be relative contraindications. This is an example of a partially exophatic right renal small RCC with placement of the RFA probe under ultrasound and CT guidance, and this is the immediate follow-up contrast enhanced CT showing complete ablation of the renal the tumor and preservation of the surrounding parenchyma. And this is the segment 6 of the liver, and we have to be very careful when we are ablating the vital adjacent organs as well. Another example, left side small RCC. This is the placement of the probes, RFA probes. The reconstructed CT images clearly shows the proper placement of the probe into the upper pole RCC in the left side, and this is following ablation where you don't see any contrast enhancement. So we usually couple the CT with ultrasound, and we do a immediate post-ablation CT just to make sure that there is no residual, as well as to exclude any complications such as bleeding. Cryoablation, similar in technique. This is the small RCC here, and these are contrast enhanced ultrasound demonstrating hypervascularity. It is partially exophatic, so these are the ideal lesions for ablation. So because we can prevent the leakage of urine and minimize the damage in the renal collecting system. So ideal lesions will be the cortical lesions, and the best lesions are like exophatic ones. This is the placement of the cryoablating probes. The patient is in the prone position. This is the immediate post-ablation CT while the probes are in the same position, and which shows no enhancement in the ablated area with preservation of the renal hilum and renal hilar fat and the surrounding the rest of the cortex. This is how you see the cryoablation, the ice ball, when we demonstrate in outside the human body. Microwave ablation, commonly used in Sri Lanka now. The technique is abundantly used in liver ablations and also in renal ablations as well, renal and lung basically. So this is another an example of partially exophatic upper pole lesion in the left kidney. This is the immediate post-ablation CT demonstrating the complete ablation, preservation of the rest of the kidney, and the spleen, the lower pole of the spleen, and there's no hematoma or any other complication. Pre-op embolization can be carried out in certain patients where you devascularize the tumor prior to ablation. So certain studies showed the outcome is more compared with the ablations without embolization. Medication and post-procedure care. The immediate post-ablation monitoring is vital. Analgesics can be administered, and the patient can be discharged on the same day if there is no complications. A follow-up of contrast CT scan is needed. The routine practice is between 4 to 6 weeks. Always we can go for a second ablation if there is any residual. Complications. The commonest complication will be bleeding, the perirenal hematoma, retroperitoneal hematomas, and hematuria can present when there is involvement of the renal pelvis, and injury to the adjacent structures such as bowel and pneumothorax is another recognized complication, and needle tract seeding can be there in rare instances. Biopsies and drainages. Just to complete my presentation, so certain collections such as presacral or deeply seated pelvic abscesses can be drained under CT guidance. In this patient, the approach is transgluteal. So over a wire, a pigtail can be placed without damaging the adjacent structures. Prostate biopsy. We commonly use transrectal and transperineal. And with the advancement of our techniques, we use fusion imaging at the moment in Sri Lanka. And this is one such example. This image is ADC mapping in MRI, where you can see low ADC values in this right lobe suspicious area. So this can be coupled with real-time ultrasound scan, like in this image. So this is the T2 weighted MRI demonstrating hypointense suspicious area in the peripheral zone of the prostate in the right side. This is the fused image, and this is the real-time ultrasound. So we can target the lesion and get adequate amount of samples. In conclusion, interventional radiology options for obstructive uropathy is vital in patient management. Embolization plays a key role in macroscopic hematuria. Ablation may offer an option in patients with small cortical tumors less than 4 cm, age more than 70 years, and high risk patients for surgical interventions. Targeted prostate biopsy is performed with MRI fusion. With that note, I would like to conclude my presentation. Thank you very much.